Thank you for the opportunity. What I hope to do today is to try and give you a slightly different perspective of a topic that you've probably heard about from other speakers many times. We're going to talk about, are statins passe? But really, to understand that, we've got to understand the LDL story as it stands today in 2021. And so I'm going to make that effort. I don't get any funding from any source. I am not practicing anymore, so I'm not taking any referrals. And I develop the content and the presentations all myself. And I stay completely current with my knowledge of cardiology because I continue to provide cardiology education and medical navigation for people in Canada and now also internationally. So it behooves that I stay very current with all the data. Okay, so why do we need or why do we have cholesterol? The reason cholesterol is there is it is required for building cell membranes, production of hormones, particularly sex hormones, processes. And at the time that we are born, Mother Nature gave us LDL level of 1.0. So at a time when the cells are multiplying at their fastest in infancy and childhood, and hormones are zinging in puberty and teenage years, and bones are growing rapidly. So even then, it seems that LDL of 1.0 is what nature felt was completely enough for us. Anyway, I'm not a very good photographer, but I took this photo last week. So this is a glass of water on my kitchen counter. And it just looks like any other glass with some water in it. Now, this is the same glass of water 2 minutes later. And if you look carefully, you see that there are two blobs floating in there. I put one drop of canola oil in there. It plopped, broke into two, and it seems like there is cholesterol floating and triglyceride floating in this glass of water, but it cannot mix, and therefore I do not understand how these fatty substances are transported in blood. And this is where the expression comes from: oil and water do not mix, or these two are like oil and water, and those kind of expressions. So the way the way cholesterol gets transported and goes around the body in the blood is that it is hidden. It is shrouded and it is hidden by a capsule of phospholipid and apolipoproteins. So these are proteins and phospholipids which are not hydrophobic, they're hydrophilic. And the hydrophobic cholesterol is hidden within the lipoprotein particle. And this way, the waxy fatty cholesterol is well hidden and travels in the body. And whenever these lipoproteins go to any part of the body, if the apolipoproteins do not wish the cholesterol to be there, it will not be stuck there. All right, so they are like delivery vehicles, the apolipoproteins. All right, so what makes good and bad cholesterol? Because cholesterol is cholesterol. So why do we say good cholesterol and bad cholesterol? So it is all about the company it keeps. This is a schematic of lipoproteins being produced in the liver, and then they are these large floaty lipoproteins, so they are very low density, and then they seem to pick up density more and more. They become intermediate density, low density, and you can see even the LDL particles are of different sizes, and the smaller they get, they seem to be able to get into the subendothelial surface, subendothelial wall of the artery and start the process of atherosclerosis. The important finding in this slide is that every one of these lipoprotein particles has apolipoprotein B attached to it. So it is ApoB that determines whether a lipoprotein particle containing cholesterol is going to get into the subendothelial space and start atherosclerosis. So it's your son. Your son's got good and bad qualities, but it's the company he keeps that's going to determine whether he gets into trouble or trouble comes to him. ApoB is the bad thing. And so it is important to remember that it is all about apolipoprotein B. On the other side are lipoprotein particles that are even smaller, and that's why they are high density. And they are all attached to ApoA. And ApoA does not allow the cholesterol to enter the subendothelial space. So it is essentially making the cholesterol non-atherogenic. And the ApoB makes the cholesterol atherogenic. So it doesn't matter if the lipoprotein particle is LDL or intermediate density or very low density. All of them are essentially, therefore, atherogenic because they are contained in the envelope of ApoB. All right. So I'm going to go through this slide. It looks complex, but the principle that is behind the information here is critical for practicing physicians. So you can see that all these lipoprotein particles, from the very large ones to the very small ones, have ApoB attached to it. They are attached to an ApoB particle. And the highest density lipoproteins, the really small ones, are attached to ApoA. And in this situation, all the particles that are attached to ApoB can be atherogenic, doesn't matter how much cholesterol they have. So the very low density VLDL or chylomicron remnants or something have very little cholesterol, but have a lot of triglyceride. Whereas LDL has a high concentration of cholesterol and very little triglyceride. And then you go to HDL, it contains a fair bit of cholesterol and very little triglyceride. So if you want to look and take an estimate of what is truly atherogenic, then you have to have an estimate of the non-HDL cholesterol. All the cholesterol that is in all these particles that is not attached to ApoA. And then you would get the best estimate of atherogenic risk. So you take the total cholesterol, you subtract from it the HDL cholesterol, and you get the non-HDL cholesterol, and you truly get the total risk. Now you say to me, why then are we so fixated on LDL? Well, LDL has the highest concentration of cholesterol, and the percentage of cholesterol in non-HDL cholesterol that is in LDL is fairly high. So LDL in clinical studies and all the epidemiological studies and research data has been the surrogate marker for all the atherogenic lipoproteins. And so we have used LDL as a surrogate marker for everything that happens with all the atherogenic particles. And for the gentleman who wanted to know a little bit about Lp(a), I'm going to be discussing this in part 2 of the presentation, but it has a very specific protein attached to it, which is not ApoB or ApoA. It is Apo(a), and it has a different degree of atherogenicity. All right, so what makes cholesterol bad is what enables it to do bad things, and that is ApoB. All right, so what should we be thinking as clinicians? Because we know in population studies and clinical trials and academic medicine, where guidelines are developed, we are looking at large groups of people, large numbers of patients or people, and the data is collected, harmonized, and then trends are picked up or cut points are noted. But for the individual patient that the clinician has to deal with, those trials and data from arising from those trials can only form a rough guideline. But for the immediate treatment of that patient in front of you, you want to be a far more accurate than the surrogate LDL number. So this is one of the first slides that came out of the Framingham study, and it's been repeated many times. And you can see it is looking at, they went to all the patients in Framingham who had a coronary heart disease event, and they went to all the people in Framingham who had not had a coronary heart disease event, and they measured their cholesterol. And you can see it's a bell-shaped situation. And there is a large amount of overlap. So from a clinical trials perspective, it points out the fact that people who have coronary heart disease have higher cholesterols. But that patient who is in front of you with a cholesterol of 5.0 could have coronary heart disease, but he could not have coronary heart disease and maybe not at risk. So that's the issue. At the tail end, on both tail ends, when the cholesterol is really low, the likelihood of coronary disease is extremely low. And at the upper end, where cholesterol is very high, the risk of coronary heart disease is very high. But you and I deal with patients who are in this mid-range all the time. And therefore, it's important for us to address those patients particularly. All right, so this is another one of those early slides that came out of Framingham, and now Mr. Fit Data has repeated it, and it's clearly showing the risk increases as your total cholesterol goes up. But we know that this is not accurate risk, because the total cholesterol is a combination of the cholesterol that cannot cause harm and the cholesterol that can cause harm attached to ApoB. So it doesn't define the risk as accurately. And you can see that there are lots of people who are in the relatively low total cholesterol range who still have a significant risk of coronary heart disease. So if we want to get more accurate with risk prediction, we can still use the LDL as a surrogate and HDL as a surrogate of cholesterol that will not harm you. And then we can do a ratio. And by differentiating LDL from HDL, we get a much better differentiation of risk with regards to the cholesterol level, not just the total cholesterol, but the LDL and the HDL. So you know now that the issue for the single patient in front of you is all this amount of cholesterol, everything attached to ApoB, and that's your non-HDL cholesterol. Something total cholesterol minus the HDL. And that's very easy to get, and the lab actually reports that to you nowadays. So is non-HDL cholesterol a more accurate, a better predictor of risk? Well, here are patients who have three different groups of LDL levels: low LDL, moderate levels of LDL, and high LDL levels. And you can see within each group, the total non-HDL cholesterol level actually further differentiates the risk and shows you who is truly at high risk within that same LDL level. So we're taking the surrogate LDL marker and we are refining it by now adding the total risk with the non-HDL cholesterol. All right. So what is the other thing about LDL that I want to explain to you today? LDL, when you order the lipid profile and you get the LDL level back, it is not the measured LDL amount. It is actually an estimate of the LDL cholesterol in the blood. It is actually calculated. And this calculation requires the measurement of total cholesterol, measured triglyceride, and measured HDL cholesterol. And then it's put into one of these formulae to see what the estimate of the LDL cholesterol is. And this is how we have been practicing and doing clinical trials. So this Fridwald equation has been available since 1972, a year after we began to learn about atherosclerotic risk from lipoproteins. And basically what it tries to do is it takes the total cholesterol, subtracts the HDL, and then it has to subtract more cholesterol from it that is in the triglyceride particles. So it uses a correction factor of 2.2. But your triglyceride could be low or could be very high, and you still use the correction factor of 2.2, you're going to get a bad estimate of the LDL. So clearly, this is the most inaccurate estimate of LDL cholesterol compared to the other two equations that are available. So when you're using the other equations, you are wanting to get a better idea of the LDL cholesterol, and therefore you want a better correction factor for the cholesterol that's attached to the triglyceride particles. So here is a graph showing the measured gold standard LDL versus the reported calculated LDL. I mean, there is a correlation, but you can see it's far from perfect. And in large clinical trials where you have thousands of patients and you've got patients on both sides in the control arm and in the treatment arm, this all washes out. But that individual patient in front of you, it does make a difference, and you're trying to see if you got the LDL less than 2.0 or 1.8, and it may actually be 2.4, and when you think it's 1.8, it may actually be 1.5. And those things matter for your treatment indications. So Martin and colleagues at Hopkins developed another equation where they put a variable correction factor. And this variable correction factor is a very complex calculation in a 180 cell matrix, which requires a software of its own and is then in the software of the laboratory. And then depending on the cholesterol, HDL, and triglyceride, the correction factor can be varying between 1.35 and 5.9 and not always dividing it by 2.2. Well, this makes it more accurate. And at every level of triglyceride or LDL, the Martin-Hopkins equation is more accurate than the Friedewald equation. And the problem is that when you get to very high triglyceride levels, even the Martin-Hopkins equation begins to fall apart. So why I'm going into the weeds here with you, it's important, just bear with me. So then the third equation that was developed very recently was with Sampson and colleagues from the NIH. And you can see it's an extremely complex equation. So it needs a computer and a proper software by the laboratory to give you an estimated LDL level. And it seems to be only better than the Martin-Hopkins equation when the triglyceride levels are very high. Well, at that point, when your triglycerides level are higher than 4.5, you're not even thinking of LDL. I mean, you're thinking of fatal or non-fatal episodes of acute pancreatitis. So you could treat the triglyceride will come down, and then you can estimate the the LDL more accurately. So this is the only time that the Sampson equation is better than the Martin-Hopkins equation. So in 2018, almost every organization that deals with lipids and cardiovascular care got together and formed a task force and recommended the use of the Martin-Hopkins equation for the measurement or the estimation of LDL cholesterol to be reported to clinicians. And in 2020, the ACC also reiterated that same finding. Well, you guessed it. All labs in BC, all hospital life labs, every one of them still reports the estimated LDL cholesterol to you using the Friedewald equation from 1972, and which is even more inaccurate at low LDL levels and high triglyceride levels. So that again brings the importance of doing the non-HDL cholesterol measurement or the ApoB measurement, which are more accurate because they come from the directly measured ApoB or the easily obtained non-HDL cholesterol level, which is total cholesterol minus the HDL cholesterol, and the rest is all bad. All right, what is the other problem with LDL? Here is a situation where a patient has an LDL of 3.3 and another patient who has an LDL of 3.3. And this patient could have an ApoB of 0.7, and this patient could have an ApoB of 1.4. And that's primarily dependent on the size of the LDL particles. And remember, I showed you that the smaller, dense LDL particles are the most atherogenic. So here, you're underestimating the cardiovascular risk on this patient, thinking his LDL is 3, which is high, but he is actually at a very high risk because he has an ApoB of 1.4. Whereas this patient, you will start treating him with all kinds of things, but he has these large, floaty, buoyant LDL particles, which have very little ApoB, so very few of them are going to get into the subendothelial space and cause atherosclerosis. So as the ApoB levels increase, your risk increases. So it's more about ApoB and non-HDL cholesterol, and the LDL can actually lead you astray. And the ApoB level measurement is not impacted by the triglyceride level. All right, so we know all this. So as a clinician, what do I recommend we do in our everyday practice? I suggest that we order a fasting lipid profile and an ApoB the first time we assess a patient for lipids, or at least once early in the course of treatment. The problem in BC is that you cannot order a lipid profile and an ApoB at the same time, unless you put something on the requisition. And the one diagnosis that you can write on the requisition, which always works, is to write complex hyperlipidemia. And then you will get your lipid profile and ApoB at the same time. Or you could just do the ApoB a few days before or after, because you can order ApoB in BC anytime you want, and you can order a lipid profile anytime you want. It's just the two together is a problem. So when you get the levels, I suggest you look at all the levels. Pay attention to the triglyceride, the HDL, the LDL, the non-HDL cholesterol, and the ApoB. And remember that the atherogenic risk is in the non-HDL number and in the ApoB number. And these two are used in the first sample by a clinician to make sure that they match and that everything is in sync. And from there on, you can just then use the non-HDL or just the ApoB to follow your treatment. Because we are using, unfortunately, the Friedewald equation for the estimated LDL in our province. And particularly when you are starting to treat and you're looking at the low LDL levels and you are trying to address whether you have adequately decreased the patient's risk or are treating him adequately, you need to really focus on the non-HDL or the ApoB level. I think I've drummed it enough. All right, so here are the guidelines. The guidelines tell you that for the intermediate and high-risk patients, you got to get it below 1.8 for the intermediate, below 1.2, and then, for the LDL, which, as you know, is very inaccurate estimate. For the non-HDL cholesterol, they say you have to have it less than 2.6. As close to 2 is obviously less than 2.6. And for ApoB, again, the high risk below 1.25 and the very high risk less than 0.8. If I turn off this slide, I bet none of us can actually really remember these numbers offhand. And with the 40 patients that you're seeing in your office, I doubt that you will actually remember exactly what number for which one, for which risk of patient. So I tell you that if you remember 1-to-1, you will be practicing excellent lipid management over 95% of the time. At birth, Mother Nature gave us an LDL of 1. And if you have an intermediate or high-risk patient, you try and get their LDL as close to 1 as possible. But you want to really pay attention to HDL, non-HDL cholesterol. And so it has a higher number, which includes other particles. So that's 2. So you want to try and get as close to 2 as possible. And ApoB, which is directly measured, the risk is somewhere between 0.8 and 1.25 is the target. Well, just remember 1. So 1-to-1 is easy to practice good, excellent lipidology in a practicing clinician's office. and you will be doing the right thing for your patient. Now, some of you will say to me, well, how am I going to know intermediate risk and high risk and all that stuff? Well, it is important that you know that. And the reason is that you have to be more aggressive with their treatment. And how do you know that? Are you going to sit in the office, in the middle of 40 patients waiting in the waiting room, and you're going to pull out that ASCVD calculator and you're going to then key in all the data? I don't think any of us really do that. We have an intuitive feeling as experienced doctors as to whether it's high risk or low risk. But I'll teach you a small little trick, and you will never go wrong. You will never undertreat a high risk or an intermediate risk patient. Any one of us can easily identify a low risk patient. It's not difficult at all. You don't need any calculator. You don't need anything. You just know the patient, no risk factors, age, female, no family history, this, that, or only one risk factor, all that stuff. And you know he's low risk or she's low risk. Well, everybody else is intermediate or high risk. And I showed you that the largest number of heart attacks and deaths from coronary disease come from the very large intermediate risk group. And that's where you're going to make the biggest difference. So I believe that 1-to-1 is valid for all these patients. All right, so summarize about LDL, the LDL story in 2021. The calculated LDL that you get reported is an estimate of the actual LDL, and it underestimates the atherogenic risk, particularly when there is small dense particles, when you have really a high risk of atherosclerosis. And this is when the ApoB levels are high in diabetics and pre-diabetics, people with metabolic syndrome, abdominal obesity, South Asian patients. It absolutely underestimates the risk. And the calculated LDL does not reflect the total atherogenic risk. Non-HDL and ApoB do a better job. So in clinical practice, we are moving beyond calculated or reported LDL, and we are beginning to now go into the era of paying more and more attention to non-HDL cholesterol or ApoB, and therefore the guidelines are also being reported in non-HDL and ApoB terms. And now the clinical trials, which still use LDL as a surrogate, now are beginning to report non-HDL cholesterol and ApoB as well. Well, that's the LDL story in 2021. Well, let's see what the statin issue is. Are statins really passé? And the issue here is that we have to bring about reduction of atherogenic lipoproteins to decrease cardiovascular risk and improve the outcomes of our patients. So are we well served by the statins? I don't want you to think that I am a physician that doesn't understand treating the complete patient. Yes, you have to look at the overall cumulative risk of the patient, and you have to have your risk assessed accordingly due to the cumulative assessment of the patient and risk, and the management has to be guided that way. And yes, I know, and you know, that about 50% of the improvement in cardiovascular outcomes comes from lifestyle changes and control of risk factors by the patients themselves. And another 50% comes from the treatments that we institute to our patients. So lifestyle measures are very important. So this is the little bit of story I go through with every patient in my office. And I talk to them my role and what is their role early on in the first visit that I see them, so that this partnership is important. And I explain to them that I am one of the lifesavers. I have to make your diagnosis correctly. I have to know which medications to use in what dose and when. And so I pick the right medications, which are the real lifesavers, or decide when you need an angioplasty or stent or when you need bypass surgery. But you have a responsibility, because half the problem with this disease in improving its outcomes is with lifestyle changes. And only you, the patient, is responsible for the lifestyle changes. And you can do it. We can guide you, the nutritionist can guide you, and so forth, the cardiac rehab people. But ultimately, it's up to you. And when it comes to medications, the physician picks the right lifesaver for that condition, but the patient has to take the medication regularly and adhere to it. So this little lecture is always there for me with my patients one time or the other early on in my care with them. So what medications do we have for lipid lowering? We have had many and we've used many, but really in 2021, it's statins. It's really statins that are used to decrease atherogenic risk. Very rarely in certain specific situations are you going to need any one of these other medications. So this slide, others may have shown you that, you may have seen it in the past. It's accumulation of multiple studies. And it actually makes a point, 2 points. First, it makes a point that it does not matter how you reduce the LDL cholesterol. No matter which method you use, whether it's bile acid sequestrants, diet, ileal bypass, or statins, the degree of risk decrease or the event rate that decreases with the decrease in LDL cholesterol is a proportionate amount, regardless of the method of reducing LDL. So if you can do it with good lifestyle measures, you're going to get the benefit, true. So for example, if you look at about 20% reduction in LDL cholesterol with any method, you're going to get a 20% reduction in event rate. So it's a 1-to-1 phenomenon with the percent decrease in LDL with the percent decrease in events. All right. What else about statins? You know this very well, but I'm going to give you a couple of points which are a little more important. You know that cholesterol is produced in the liver, and there is this pathway, and HMG coenzyme reductase is an important enzyme that makes mevalonate from which cholesterol is made. And that statins block this enzyme and therefore block the production of cholesterol. Okay, so cholesterol production is stopped in the liver. That is not why the blood cholesterol comes down. What happens is the concentration of cholesterol in the liver cell drops. By a feedback loop system, the LDL receptors on the surface of the liver cell are upregulated. They become very much more efficient and increase in number because they get the signal that there is less cholesterol in the liver cell. So they suck out the cholesterol from the blood and therefore clear the cholesterol from the blood. And this is how the blood cholesterol lowers. So the point here is that statins work through the system of the LDL receptors. And this is why familial hyperlipidemia, heterozygote or homozygous, is a problem with the LDL receptor. And there are 3 major mutations, and they all deal with either the LDL receptor directly or with how the LDL receptor functions. All right, so we learned that from nature, and we are now following that pathway. The other point I wanted to make on this thing is that this does not only happen in the liver. It happens in other organs as well, muscles, the intestine, the adrenals, the skin. And so the statins will also work in those areas and do its thing because that process is there in other organs, but to a much lesser extent than it is in the liver, which is the major factory. All right, so you've seen this slide, makes a couple of points. It combines all the secondary prevention trials. So a patient had a clinically apparent coronary disease of some kind. And then you reduce the LDL cholesterol, where you are able to decrease the coronary event rates. And in patients who clinically have not presented with a coronary event, and you reduce their cholesterol, their risk of having another event goes down as well. But the point is that it doesn't matter where you start your LDL cholesterol level from. Like in the 4S trial, it was very high. And you bring it down to here, the percent reduction will determine the percent reduction in the event rate, like I showed you from the Robinson slide. And the same holds true at the primary prevention level. If you drop the cholesterol by 20%, you're going to get a 20% reduction in risk from baseline. The baseline was low, but you're going to lower it further by 20%. All right. So don't have anybody ever tell you that statins don't work in primary prevention. So if you combine all the trials and you have 90,000 plus patients in randomized statin trials, and you look at what is the effect of 1 millimole reduction of LDL cholesterol, then every time LDL cholesterol is reduced by 1 millimole, there is about a 21 to 22% reduction in coronary event rate. And essentially all the major coronary events are decreased with dropping the LDL cholesterol, which is the surrogate marker, and all-cause mortality also decreased, but patients still die from other causes. So total mortality doesn't decrease the same as cardiac mortality, but it decreases significantly because you have decreased cardiac mortality. But as a percentage, you get a lower reduction because people are still dying from other causes. All right, what's the next thing about statin therapy that we need to know? This slide, all the patients had an acute coronary syndrome and statins were started immediately and they were then followed. And they were followed regularly to see when did the risk of a second event decrease in these patients who were taking the statins. And you can see within the first 4 to 6 months, the hazard ratio starts dropping significantly. Like for another ischemic event or presenting in hospital with an acute coronary syndrome, is already dropped by 50% in 6 months. There is no time to change the progression or cause regression of atherosclerosis. So how does this happen that it happens so quickly? Well, it is all about the plaque, the atherosclerotic plaque. What statins do is change the composition of the cholesterol and the inflammatory cells in that vulnerable plaque and make it more stable and less vulnerable and therefore less likely to pick up a thrombus and cause an acute coronary syndrome. So statins do their job in different ways. They do slow down the progression of atherosclerosis, they do cause regression, but they do, the immediate job they do is change the composition of the atherosclerotic plaque. All right, another concept about statins that you've probably heard of. You know, we used to always talk about, you know, we did a history and we presented to our attending and we always say, this patient has a 20-pack year history of smoking, or he has a 10-pack year history of smoking. So he has a 20-pack year history of smoking, and he may be smoking 1 packet a day for 20 years. Or he could be smoking half a packet a day for 40 years, or 2 packets a day for 10 years, and the risk is the same. It's all about the total exposure to the nicotine and the harmful substances to the lungs. It's exactly the same thing with cholesterol. It's all about cholesterol years. How many years has the cholesterol been elevated in that patient? And that is going to determine how much risk he is at. So higher the cholesterol and longer it has been present, you can see the event rate at the age of 55 is at least 3-fold what it would be for a lower cholesterol level, which was only up for a few years. So we are beginning to understand this concept of cholesterol years rather than just the level of cholesterol. Looking at the other side of the coin, well, let's say you reduce the cholesterol by 20% and you start doing it at someone at the age of 20. Yes, you will get a 20% reduction in their event rate. But if you start reducing the cholesterol at the age of 50 or at the age of 40 by 20%, you will decrease the event rate much greater. Now that data I showed you, 20 for 20, 1 millimole for 20, was all comers in large groups of patients. Here I'm talking to you as a clinician. If you start lowering the patient's cholesterol as early in life as possible, you're going to not need to lower it as much, and you're going to get a much better benefit in the long run. All right, so that brings us to the question of how low are we going to take the cholesterol? And we're using LDL as a surrogate. All right, so how low? So let's take people who are already at target. So they already have a cholesterol of 1.8, which is less than 70. So they've less than 1.8. So they've reached all guidelines, and therefore there is, you would think, no need to be more aggressive at that point. Well, if you look at these people, and these are over 5,000 patients in the treatment arm and the control arm, and you can see that when you lower the cholesterol by 1 millimole, even at 1.8, and you go down 1 millimole, you get the exact hazard ratio drop to 0.79, which is a 21% risk reduction. It holds true at any baseline level of cholesterol. So is 1.8 good enough, or do we need to lower it further? Well, let's look at regression progression. And we can see that progression of LDL, progression of atherosclerosis, seems to stop around LDL of about 1.6, 1.8. And regression seems to start when your LDL starts dropping below 1.5, particularly around 1.2. So now we say, okay, well, that's excellent. That's very beneficial. Maybe we should aim there. And but do we actually see a decrease in events? So here is that standard line, all trials, and you're dropping the LDL lower and lower. And there are now trials using PCSK9 and other lowering, cholesterol lowering medications that have large numbers of patients who have LDL of less than 1 upon treatment. And it is now clear in those trials that your risk level keeps dropping all the way down to at least 0.4 millimoles per liter of LDL. So it seems like we are getting benefit all the way down to that level. Do I recommend that clinicians should try and get patients to 0.4? No. Why? Because you say, okay, high is bad, average is good, lower is better, even lower is better, maybe go lowest possible. Yeah, it's true by and large. And if you look at the more recent guidelines, and the Europeans are more pragmatic in the way they treat lipids compared to us in North America, and you can see that from their outcomes, you can see they've gotten to a point with very high risk patients, they stop at 1.0. Remember that number that Mother Nature gave us? And it seems to be a very important number. Well, what happens if you lower it below 1.0? Well, if you drop it below 1.0, you get more regression. I told you, all the way down to 0.4, and you get less coronary events all the way down to 0.4. But by that time, below 1, when you get to 1.1 or below 0.8, your event rate is extremely low. So you're going to drop very low event rates to very, very low event rates. Yes, it may show up in 10,000 patient trial, but it's not going to be good clinical medicine for that one patient in front of you that you are trying to completely overtreat, and which is not a good thing to do. Why it is not a good thing to do? This is a paper published this year in January 2021, looking at the risks of dropping LDL cholesterol below 0.8, so below 1. And you can see there is more concern about the development of diabetes in these patients. More hemorrhagic strokes, not ischemic strokes, are decreased, but hemorrhagic strokes, and for increased production of cataracts. None of this has been proven because we are now just beginning to get these patients with LDLs less than 1 because we're using these stronger medications, PCSK9 inhibitors and others. So I caution you, as a clinician, don't try to improve on nature. Stay with the 1.1 formula and concentrate on the non-HDL and the ApoB. And this is a very easy thing to remember. Everybody is at risk in your practice. except the low risk patients. Those are easy to identify. You do not need a risk calculator to do that. And everybody else is intermediate risk or high risk. Treat them properly. And I told you that the vast number of heart attacks and deaths occur to people who are in the intermediate risk range. All right, so what is the problem? So statins are so good. So why am I saying statins are passé? Or what is the reason why we are looking for other agents? Well, statins have limitations. They have adverse effects. They have variability of effectiveness and variability of side effects. The same drug at the same dose will bring down the LDL differently in patient A versus patient B, and the patient B may get a side effect and patient A may not with the same drug at the same dose. That's the problem with statins. They're extremely patient specific. Adherence is a problem long-term with the medication you are taking every day. And some of these patients are taking antihypertensive meds, diabetic meds, antiplatelets. So it makes it very difficult with polypharmacy. And then the other problem is that we know we have to get LDL cholesterol levels really down there to really decrease risk in these high-risk patients. And the statins, in many cases, are unable to get us down to that level in the maximally tolerated doses. I mean, they may tolerate 10 milligrams of rosuvastatin, but they're not tolerating 40 milligrams of rosuvastatin. And so at the maximally tolerated dose, you are unable to get the LDL low enough in order to help that patient. So what are the statin limitations? Adverse effects. I want to mention to you a concept. You all know about the placebo effect, that you think you took a sugar pill, but it was a real drug and you got the benefit because of it, and that's a placebo effect. The nocebo effect is the other side of the coin. When patients get symptoms and they're taking statins, it is not necessarily the statin that's causing the symptoms. Many men die with prostate cancer, but not many men die of prostate cancer. You got it. Right. And when you have the lay press, the internet, family and friends, anecdotal cases, doctors who are concerned, pharmacists giving them all kinds of lists of side effects, and the nurse being overzealous in our education and talking about statin side effects and stuff, all that drums in the nocebo effect. And there's a paper published this year, which is primarily looking at the nocebo effect and how strong that is in patients who are given all this information versus those patients who are treated in a prudent way, as normal clinicians would treat them. So that's the one thing about adverse effects. This slide caught my eye a few years ago when I was at a conference. So I took the picture from the audience. So it's not a perfect slide, but it makes the point. Aspirin. About 250 people who are taking aspirin will get a GI bleed, minor, mild, severe. And about out of 2,000 of them, one of them will actually die of that GI bleed. On the other hand, it takes 100,000 patients treated with statins to get one severe case of myositis. And for that myositis to kill that patient and be fatal, takes 1 million patients treated with statins to find that one patient. That's the perspective of it. All right, so what are the adverse effects? You know about the myalgia issues. It is real. Statins do cause myalgia. And in some patients, it is extremely bothersome and they cannot manage it. And there are many tricks to manage myalgia in clinical practice, and we can discuss that later on tonight or at some other time. And there is this concern about new onset diabetes when you are bringing the LDL cholesterol down too low. And then the issue of myositis, it's extremely rare. You get liver enzyme elevation, but rarely over 3 times the upper limit. And to get actual liver dysfunction is extremely, extremely rare. I have been using statins since 1987, And yeah, I wrote the first prescription for Mevacor in this country, and I'm proud to say that. I was involved in the research trials for Statin, and then I had patients in my trial who were now no longer going to get Statin anymore, and they were obviously needing it. And so I had the thing with the pharmacy the day the thing was approved and the Mevacor arrived. I was writing a prescription for these patients who were truly benefited. Most of these were heterozygotes or homozygous familial hyperlipidemia patients. And with all that experience, I have never seen a case of severe liver dysfunction with statin. But I presume it occurs. And there is this concern about cognitive function. So what is the other problem with statins? They are patient-specific. Some drugs are specific to the disease. Well, you give them this drug, they have this disease, it works. Statins are patient-specific. The same dose, the same drug will do completely different things in that patient in terms of the benefit and also in terms of the side effect. Here's the data. Every one of these patients, each line is a single patient. Every one of them got 10 milligrams of atorvastatin, which is Lipitor. And they either did not decrease their cholesterol at all at that dose or decrease their cholesterol over 50, 60%. Look at this variability. You do have to remeasure their lipid levels and see the response and understand that statins have an extremely variable effectiveness profile. And therefore, they are difficult drugs to use, and you have to monitor your patients specifically what is happening to them, not what happens to group data from clinical trials. All right, what's the other problem with statins and their response? Statins have a flat dose response curve. What do I mean by that? You give it a dose, and you pretty well get the full effect at that dose. So at the starting dose, 10 milligrams of atorva, 10 milligrams of rasuva, 10 milligrams of simva will drop your cholesterol very significantly. And then if you double the dose to 20, 40, 80 milligrams of atorva, you get very little extra benefit. So you have not reached your target levels, but it is not going to be very possible by keeping on upping and upping the dose of statins. Well, you have to as much as you can, but you will increase the side effect profile, particularly that of myopathy and myalgia. So that is the problem with statin. There's another limitation. The big limitation is adherence. I mean, side effects are a problem. You have the nocebo effect that you are fighting, that we will never win with the statins as long as we practice, because the media has just taken hold of this issue. There's polypharmacy. A patient is fine last week, on no medications. He's 46 years old, gets an acute coronary syndrome event, ends up in the emergency, has a non-STEMI EMI, gets an angioplasty and a stent, and he leaves the hospital with aspirin, ticagrelor, statin, a beta blocker, pantoprazole, so he doesn't get a GI bleed. And if he also has hypertension or has had some LV function problems, he leaves with a RAS blocker. If he's a diabetic, we're controlling all the risks, so he's on diabetic meds, and then comes inflammation, we're going to hit him with colchicine. It is very difficult to maintain adherence of polypharmacy lifelong therapy. And that's a limitation of a medication like statin, where you have to take a tablet every day. All right, what is the harm in statin adherence? Is there data? And you can see whether you're looking at a recurrent MI or you're looking at all-cause mortality. It's only when you are taking statins more than 80% of the time that you actually get a significant decrease in all-cause mortality or recurrent MI. So adherence is an extremely important issue. Now the other side of the coin. What if you stop the statin? This is a very bad slide. I took the picture earlier this month. This is from June this year. So it is earlier this month that this came out. All right, so we're looking at patients who were on statins over the age of 65 who went ahead and stopped their statin for polypharmacy reasons or whatever. And then these patients were followed to see what happens to them. And we looked at hard events that they ended up in the hospital. So they either required hospitalization or ended up in the emergency room with an acute coronary event, or actually had mortality. And you will see that the risk of ending up in the hospital requiring hospitalization for a cardiovascular event, or increased mortality, or increased ER admissions is worse when you drop suddenly or gradually, but suddenly is the most harmful statin, and you get the reverse risk. All right, so statin limitations, inability to reach the atherogenic level profile that you are asking for. And reaching the targets is very slow. So the last two slides summarize the talk. We want to get to lipid levels low enough to decrease the risk, and oftentimes statins don't take us there. And I want you to remember, and I want to drum it into you for clinical practice. All you need to remember is 1-to-1. All right, so the LDL story. Cholesterol is cholesterol. It needs to be shrouded in protein and phospholipid to be transported in blood. It is the lipoprotein that determines whether that cholesterol is going to cause harm or not. And lipoprotein B for bad, is the one that causes the atherosclerosis because it allows the cholesterol to enter the artery wall. And ApoB itself is atherogenic. Any cholesterol transported on ApoA cannot get into the artery, so it is non-atherogenic. However, there are limitations also of the calculated LDL level that I told you about. And I told you that the formula that we are using in BC is the most inaccurate. And it is a problem when you're dealing with small, dense LDL particles in diabetics, South Asians, and others. And always remember, non-HDL cholesterol and ApoB are going to be your best guide. So in clinical practice, we're moving away from the calculated LDL to the era now of the non-HDL cholesterol and the ApoB levels, and the clinical trials are also moving that way. So it is the triad of this thing where ApoB and HDL cholesterol, non-HDL cholesterol predicts the risk, the three sides of the coin. Inside the coin, whether it's gold, silver, or nickel, or whatever, the ApoB and the cholesterol that comes with it is actually integral to the atherosclerotic process and causes the atherosclerosis, and lowering it, the other side of the coin, improves the outcomes. So are statins passé? Well, we've come a long way with statins, and there's a remarkable decrease in morbidity and mortality. But statins have limitations, and we therefore need to embrace newer medications. But these newer medications have to overcome the limitations we have with statins. Otherwise, there is no point to jump to another medication if its limitations are worse. So in part 2 of this series, I will be happy to tell you where we are going beyond statins and which are the newer drugs that are available today or just around the corner or very soon in the near distant future. And they actually will overcome the limitations of statins. And we're going to talk a little bit about Lp(a) and HDL at that webinar as well. Thank you very much, and I apologize for going slightly over time.